So now we are going to discuss chapter 24, neurosurgery. So if you pay attention, the first couple of slides are really just anatomy review stuff. I'm not going to go over that a lot. It's in your book. Most of this stuff we have covered. I feel like we've covered several times before. Couple of things I do want you to pay attention to. The different hematomas. So epidural hematomas. Epi is above, okay? And subdural will be that area between the dura, so between your different layers to the brain, okay? So what happens is you have to be very careful with that, because with subdural hematomas, if they are left untreated, the more they bleed out and spread, the more damage that they're doing to the other vessels around them, because they're actually stretching and ripping those vessels. And eventually your patient is going to pass out. They can potentially go into a coma that they can't recover from. So you have to be really cautious with that. That's why hematoma evacuation is a pretty big deal whenever it comes to neurosurgeries. Let's see. So the next one, this is just talking about basic portions of the brain that we've discussed before. Your cranial nerves, please review those. If you do not remember them, those will always be important. I promise you. Circle of Willis, of course, is at the base of the brain. All of your main vessels are coming in. It creates that ring of vessels around the spinal cord where it's connecting in at the brain. The main thing to remember about this, so when it comes to aneurysms, and we'll talk about this in just a little bit, the actual bifurcation point at the circle of Willis is the most common spot for an aneurysm. Because think about it, when you're bifurcating, you're going from one vein and you're branching off to go around something. So when you have a lot of force, it's going to pick path of least resistance. So when you have two little areas branching off, all that blood flow is coming in at one point. So it's almost creating a balloon whenever you have too much pressure to branch off, okay? So that bifurcation is really going to be where you see those aneurysms. Stop. The joys of being at home. Okay, moving on. So instruments, basic instruments that you have to know are used in neurosurgery. So basic things, the Langenbeck, it is a periosteal elevator. So a lot of times they're going to use that when they're working around the skull, okay, to kind of peel those layers back. You have your dandy clamps. If you have done neuro, especially any kind of head stuff, I'm sure use those dandies a lot. They're very similar to Krauss. Let's see, your Taylor retractor. That one is actually more of a surgeon preference. It depends. I haven't seen, but maybe 2 surgeons ever really use that. But your Myrdings, those will be used in almost every single back case that you do. Those are your go-to retractors because they provide a pretty good wide area to like kind of separate those muscles back. And they're deep enough so that they're really retracting it and opening up that space for you to be able to see into the spine. And lastly, I put on here patties, because I want you to know, depending on where you go, Sometimes your surgeons or your techs will refer to these as YASs. I'm not sure if North does that, but I will tell you a lot of times. So most places call them patties. Some places call them a YAS. So just keep that in mind. It's short for Yazergill. So if someone asks you, you know what the heck that is. Most of the time, your patties are used for your hemostasis. They'll soak them in thrombin, and that's what they are actually putting into that spine to set for a minute to kind of soak up and to stop a lot of bleeding. Next, we have your Rainy clips. So Rainy clips are important, especially if you're doing craniotomies or you're working around the skull at all, because that is what you're going to put on as you cut down around that skull and you flap it back. The Rainy clips are going to help with your hemostasis of the scalp, but it's also going to provide a little bit of retraction so that you can see what you're doing. Next, you have your aneurysm clips. I don't know who all has experienced this yet, but sometimes those things fly off, so be very cautious with them. You can have clips, cools, all different kinds of things whenever it comes to aneurysms. I have accidentally shot one of these across the room before. I wanted to cry. So be very cautious. Make sure that you're kind of keeping your hand underneath it just as a backup. Next is your Hudson brace. That's a little old school. We kind of used to use those back in the day when, you needed quick access without really putting tons of pressure and power to someone's skull, because you really wanted to kind of hear it so that you could tell how far down you were going. This is kind of a little more old school. It depends on the surgeon preference. Some surgeons I've worked with think it's way outdated. Some still believe that it is the safest way. But I will tell you, this may show up on some of your practice boards and your boards. So I really just wanted you to know about that. And then you have your Layla Yazergill retractor. So it's pretty cool. It reminds me of the guy for Spider-Man. So when you actually hook this up, you have these flexible arms that are going to be able to attach to what they call brain spatulas. And so your spatula, you can actually bend it however you need to place it, and then you don't have 5 people up there in the way trying to retract back. So it's really nice. I really like those. Let's see, moving on. So earlier we talked about the Wilson frame. So with the Wilson frame, you're going to be placing that patient into prone position. The Wilson frame is actually that rounded portion that's going from her axillary to about the pelvic bone. And they will arch that up or down depending on how much access they need to open up that spine. So if they need more, they're going to kind of pump it up higher. Less, they can kind of lower it down. So sometimes they'll actually lower it down when they're closing their incision to kind of bring that skin and the muscle back together. Next, you have your Mayfield. I will tell you, these give me such severe anxiety. Here's the deal. Once your patient is placed in that Mayfield headrest, most of the time they have tongs that are attached. Please do not mess with that Mayfield at all. Don't bump it. Don't do anything, okay? You need to treat it like it is the most delicate piece of equipment you've ever seen, because that's literally what is holding on to their head off of the bed. If that happens to fall, their head is going to be going with it. So be cautious of that. Next, you have your Andrews table. So a lot of places that are more specialized in neurosurgery will have these. I believe North has this. I'm not really sure. I'd have to check that. But they're more specialized so that they're able to accommodate their patients a little easier, instead of just using a Wilson frame to put on an OR table. So let's go down. Okay, we're gonna get started with our surgical procedures. So one of the most, I say basic, but it is a pretty in-depth procedure that you will do in neuro is a craniotomy. Craniotomy is used to do several different things to access the inside of that skull, okay? Doesn't necessarily have to be inside the brain, but it is access for anything underlying that skull. So craniotomy, you need to know to actually begin your craniotomy. If you look over to the right, you will see the patient who they've already created a skin flap. They've gone around, used their Rainy clips for hemostasis. And first you have to create those burr holes. So when they create the burr holes, it's not just relieving pressure. You also have to kind of think of it as a connect the dots situation. So by creating these burr holes, they're able to go in with their saw, which should always have what's called a dural guard on it. So they will go under that hole and actually drill around to the other hole. So they're connecting the dots. That dural guard looks like a little hook that goes under the bone, and it keeps that saw from perforating down. So they are connecting the dots to where they can actually pop that bone flap out so that they have access to everything. And by creating those holes, it's actually going to be easier for them to close that back together when they're done, because they can plate over that. Let's see. We talked about scalp hemostasis with the Rainy clips. This is cool. I can't believe I was about to forget about that. So, depending on the patient's situation, if for some reason they have excessive brain swelling, they can take that flap and freeze it so that they are able to leave that space open for the brain to swell and eventually go back down. To me, I think that is just like the coolest, craziest thing. One thing that they do, and I'm going to try to find the video and upload it, is they have actually started implanting the bone into the patient's abdomen because it nourishes it with healthy nutrients from the body and it keeps it protected, which I think is the coolest thing ever. And then once it's time to replant it, they will remove it from the abdomen, reattach it, close all that back up. It's really crazy. So some of the reasons why you can do a craniotomy. We've already talked about your evacuation of hematomas. Aneurysm repair is another one, and then tumor resection. So if you have been to North or if you have heard other classmates talking about it, that is one of the main things they do there is tumor resection. And so with neuro, a lot of these can all kind of be grouped together. So An aneurysm repair doesn't necessarily have to be a completely separate case than a craniotomy. You have to have that to be able to access the aneurysm a lot of the times, unless they're able to do it vascularly, which is very tricky, but very cool. And that's where actually some of the stereotactic stuff can come into play. Okay, sorry, I'm getting off on a tangent. Okay, so next, very basic. I know y'all are probably hating my PowerPoints because they're very plain and white and boring and they don't have a lot of color and prettiness to them. I'm doing this to save ink for people that are having to print off of their own printers or whatever. I don't want to have a big, bright, colorful thing and you print it and say, oh crap, I'm running out of ink. There's no reason to go to Walmart right now for that. Okay, anyway, so aneurysm repair. A lot of times, this is what makes aneurysms so scary in the brain. A lot of times, you are asymptomatic until it is too bad. Sorry guys, I'm choking to death over here. Okay, so like I was saying, with aneurysms, you're pretty asymptomatic until they get so large that they start to compress and you have dizzy spells or you pass out. Some patients even start to feel like they're gonna be very ill and nauseous. At that point, sometimes it's almost past the point of anything being able to be done. So those can be very scary. Typically, at the bifurcation of Willis, like I've already talked about, sometimes you can use papaverin, which can actually prevent those vasospasms. So it can kind of relax that and not have that, if you want to think about it as almost having this built up blood pressure, because that's essentially what it is, that papaverin is actually going to cause a muscle relaxation almost of the vessel. So, most of your diagnosis is going to be done through cerebral angiography. So they will be running a catheter up, or they will be using fluoro in radiology to check that. That is the best, most accurate way to check for any kind of aneurysm. Okay, let's move on. Cranioplasty. So all a cranioplasty is remodeling of the skull, okay? It can be during surgery, after a trauma, after a defect, anything like that. All you're doing is replacing the bone. You can either use a synthetic graft, or what's even kind of cooler is now that 3D printers are all the rage, you're seeing a lot of that being used to make these prostheses. So they're able to customize just for each patient, which I think is awesome. One thing that was kind of discussed under your cranioplasty portion was Chiari malformations. So some people do know about Chiari malformations, some people do not. So what happens is actually you have, I think there's 3 different types or degrees depending on how bad the malformation is. But what happens is most of the time you see like the cerebellum and what's called the tonsils. They will actually, if you look over to the right, you'll see that that lower portion of the brain is actually sliding into the area where the spinal cord is. So if you look over here to the top right, you'll see a normal, supposed to be normal anatomy. And to the right, you will see that Chiari malformation where that cerebellum is starting to push down into that spinal canal, into that spinal column. And it's actually, that causes dizziness, headaches. People can experience like blurred vision. They can experience certain speech issues. So it's pretty interesting. Some people experience sleep apnea because think about it, all of this stuff, it's essentially going to make the rest of the anatomy in a little bit different area as well. So to fix that, what they do is they go in and they will remove that posterior fossa, okay, to allow extra space so it's not compressing in on the spinal cord, which I think is pretty cool. Okay, next we're going to talk about craniosynostosis. I think this is a pretty unique procedure. So if you're ever looking for something to kind of do a report over, I think this is a great one to pick. So whenever it comes to craniosynostosis, so what it is you actually see this in children, little babies, when they're born. So you know we have all these suture lines on our head where all the bones in our skull come together. Well, for babies, those suture lines are squishy and movable, and that's why your babies have those soft spots to accommodate for their growing brains and as they get bigger. So babies that actually experience craniosynostosis have a fusion. So those skull suture lines are fused together, okay? So as the baby is growing, it's not able to accommodate the growing brain, okay? When these babies are little, that needs to remain open. So a lot of times now they're kind of going in and doing almost like a laparoscopic incision, a little incision, putting a scope through and opening up the suture lines. The most commonly affected suture line is that sagittal suture. They usually try to perform this between 6 weeks and 6 months, so that's important to know. And knowing that sagittal suture, that's really important because I think I've seen that question come up a couple of different times. But yeah, that's a pretty interesting procedure, and it's really cool to see the before and after results for these babies. Okay, next we're going to talk about craniectomy. If you have been in any neuro cases or even ENT, some ENT procedures use stereotactic things. So all this really is, stereotactic procedures are image guided. So I'm hoping that y'all are able to get back to North as soon as we can, because you actually do see a lot of really cool procedures there that are, sometimes they'll call them stealth procedures. You'll see that they will hook them up. They've already kind of mapped them out ahead of time. And so when they come in, they will actually have these little stickers all around, and they're called fiducials. Okay, so these fiducials look like little Cheerios stuck to their forehead and all around. What these do is they will actually have a pin and they will map it most of the time, and it helps them to figure out exactly where they need to go in to do a tumor removal. One thing about this that's kind of tricky though, I don't know if any of y'all have experienced this. So if the surgeon is super proficient at these cases, it goes very smoothly, and you don't really see a lot of unexpected things. It still happens occasionally, but not as much if they do this on a daily basis. So one thing you see that can be a little tricky when using stealth is they have it mapped out. And we're talking about tumors here, guys. These are, most of the time, very fast growing cancers. So when that happens, sometimes the anatomy isn't always the same as it was when they first mapped it out. So that's another reason why stealth and stereotactic procedures are actually really beneficial, because then you can reassess the anatomy before you go in and just start cutting like crazy. So I'm a huge advocate for those. I think it's very neat. If you are ever interested in looking something up, if you want to learn about a certain cancer, I will tell you my cousin has what is called multiform. She has glioblastoma multiform. And so she has had several of these procedures, and it's just crazy to think that they do all of this stuff. So if you ever happen to have some free time, like now, look that up. You will learn a lot of crazy stuff about it. Okay, moving on. VP shunts. I like to do VP shunts. I think they're pretty cool. So, basic anatomy review. Of course, your ventricles in the brain are filled with fluid. They're filled with that CSF, which nourishes the brain, okay? Your CSF is produced by your choroid plexus, okay? So you have that circulation through there. Once it's circulating and it needs to be reabsorbed, it's reabsorbed at what's called the arachnoid villi, those little finger-like projections that soak it back up, okay? We've talked about that several times before. So, when we talk about anatomy of the ventricles, I want you to remember we talked about those aqueducts. Aqueducts refer to water channels, right? Okay, so when you hear aqueducts, Monroe, Sylvius, okay, Lucia, those are the main ones that you are going to hear about. So, Sylvius, the importance of it is it connects the third and fourth ventricle. So, I'm not sure if you're able to see very well on this or not. Not great, huh? Well, so if you're able to kind of zoom that image up, it'll help you kind of see that little aqueduct running through there that connects them. So I want you to know that, because I promise you that will show up on a board question or in your practice boards. You may have already had it. So one reason, pretty much the main reason that you will do VP shunts is because of an obstruction. You have an obstruction and that CSF is not able to drain. So they're actually going to go in. If it's not able to drain and it goes on for too long without any way to drain out, you develop hydrocephalus, which is that swelling, okay? So they will actually go in with this little catheter into the lateral ventricle, okay? And so they put it into the lateral ventricle, and then they will run the rest of that shunt, shunting it away, right, So bringing all that fluid down, and they put it in the peritoneal cavity. So that shunt is relieving all the pressure. It's passing the excess fluid away from the ventricles and into the peritoneum, where it's just reabsorbed into the body. So pretty darn cool. All right, moving on. Next, you have, I think this is a really cool, Jenny, get down. A really cool procedure, which I guess pretty much all of these procedures I think are really cool. A transsphenoidal hypothesectomy. So sphenoid, remember that is the important part because you're working through the sphenoid sinus, okay? So transsphenoidal hypothesectomy. So this is actually going in and removing a pituitary tumor through the nose, which is crazy. So, because remember I said you have that sphenoid bone, which is that very thin bone that goes in between your sinus cavity and your brain. So, when you do this procedure, you're going to go in to get to that pituitary tumor, and what I want you to know is the pituitary sits on the sella turcica, okay, or turcica. Let's see. One thing to remember, after your patient is done, if you see anything, even if you think, hey, they have a runny nose, be very cautious of that, because what could it be besides dripping snot? It could be CSF running out. If that is the problem, you need to reassess that patient, okay? So once all of that's done and they feel confident that they can move the patient to recovery, they're going to start to pack a petroleum nasal packing up in their nose, okay? Because you will have some bleeding. But it's actually a really cool procedure. And who can help assist that neurosurgeon? An ENT surgeon. Because you're actually passing through that sphenoid sinus. So, cool. All right, next is just a basic review of anatomy of the spinal cord. Just reminding you of C1, C2. Sorry, I have the hiccups. C1, C2, your breakdown of different vertebral columns. Let's move on, because this is where we're getting now into the back anatomy. We went from the head, now we're going to the back. Okay, so basic anatomy, basic cases that you're going to do that can turn into very long cases sometimes. Your lumbar laminectomies. You can do lumbar laminectomies, discectomies, or you can do a fusion. So, if you do a PLIF or an ALIF, that is a posterior lumbar intervertebral fusion, okay? Most of the time, these are a trip. As y'all are learning, you can also have an orthopedic surgeon to do these, as long as they are not doing anything with the spinal column or any of the nerves. Okay, so some basic things I want you to go over and review is the different parts of the actual disc itself. So, one of the things that happens is you have this disc, and as it starts to herniate, you start to have impingement on the nerve. So over to the right, I tried to put an image to kind of give you a little visualization. So you have the nucleus pulposus, and then you have the annulus around it, which is going to be more fibrous. The inside is going to be more water-based, okay? And it dries out the older you get, so that's why you kind of see that herniation in a lot of older people. Let's see. We talked about vertebral bodies, compressed, degeneration, trauma, osteophytes. So a lot of times when you are in those cases, you're going to see them use like their ronger because they're taking off those osteophytes or bone spurs so that they're able to kind of open up that space a little better. Most of the time, to diagnose that they have a herniation, they're going to use a diagnostic myelogram because myelo is for the nerves, right? Myo is for muscle. So I kind of broke it down and gave you a basic review of when you're doing this case, what you should be using on each individual anatomical structure. So when you are using your pituitary ronger, which is also referred to sometimes as a Takahashi, you're actually pulling out pieces of the disc. So that disc can be kind of squishy, and you need to make sure that you're cleaning that out each time you can. Whenever it comes to your Kerricins are used more for bone, so that lamina that is sticking out, that's what they're going to start to take off. And then, kind of, it pulls back on it and bites chunks out. Your Lexel is that double action ronger, and that's to take off that spinous process that you can kind of run your hand down your back and feel. So the Lexel is used to remove the spinous process. I kind of did this backwards, so you would actually kind of start from spinous process, lamina, and then the disc. Once all of that's done and they've opened up that space, most every surgeon is going to end up doing plates and screws. If it is big enough, if they end up having to do several levels, they will do what's called a cage. So it's just a long piece of plates and screws that will go in and fuse that area that you just took everything out of. If they do like a micro decompression, they can use like little tubes and work down in those with a microscope. A lot of times you can see them do that in lateral. A lot of the doctors in Jonesboro still put them in prone position. Okay, moving on. So this is just showing you your pituitary or Takahashi that we've talked about. You have up biters. You can have different right, left, down. Working out and figuring out the best way to put those on your Mayo to keep up with them, that just kind of comes with time. And then you have your Kerricins, which go up in size. Normally you start with 2, it just depends. That's kind of surgeon preference, but you want to start small and work your way up. And then you have your Lexel or your double action ronger, which we said is for your spinous process. Once again, I'm stupid and I put these on here. I did add the Hall frame. That's a little different. You don't see that used quite as much as the Andrews and the Wilson. Okay. Moving on, this is probably one of the most common procedures that you have seen on the board, an ACDF or an anterior cervical discectomy and fusion. So the purpose of doing this is to treat that spinal stenosis. So people that have a lot of pain that runs down the shoulder, like myself, it is normally because you are experiencing spinal stenosis or narrowing of that spinal column. So when you have that narrowing, you start to get that nerve pain because it becomes pinched. So they need to actually open that space up, and most of the time, the easiest access is to do an anterior approach. So they'll make an incision through here, usually using one of the Langer lines so that they're not creating a new incision on the skin. Be aware that if you are assisting in these procedures and not passing, you are in charge of retracting these structures over. So don't pull too hard or you're going to cause a lot of issues post-op, okay? Pulling close to the carotid artery, okay? You're retracting the esophagus, the trachea. So by pulling on that, you're going to cause a lot of hoarseness, and it could even potentially cause some much longer issues, okay? So be aware of that. Don't just put your retractor in there and pull back. Ease on the tension, okay? If you're ever unsure, ask. Whenever it comes to the ACDS, you usually have the option of using Cloward instruments over to the right. This is just a basic image of your Cloward. This is one of the pieces that comes with a Cloward instrumentation. A lot of times you will have a rep tray of Cloward instrumentation. This is just your little retractor to kind of work your way up. Remember, size of your patient helps to determine size of the blade that's going to be used. One thing that does come in your Cloward instrumentation is a color-coded rod. A lot of times they'll call it a rainbow rod. That will help you because it is color coordinated. A lot of times that will help you figure out what else you need to get out of that instrument set. So that's just a little tech tip for you. They do tell you that the best option is to do a possible bone graft from the iliac crest. And so instead of using a cadaver bone to implant, they'll say to do that, which it is because it's coming from yourself. But the easiest, most convenient way is to just go ahead and use a cadaver bone. And most of the time, it's a radial. I believe it's a radial bone. I'd have to look at that again. I can't remember. Okay, so that is one of your very common procedures. Next, you have a rhizotomy. Not a ton of people do this in the OR. This is really for like outpatient pain centers and pain clinics. Let's see. So the purpose of doing these rhizotomies, and they may not technically call it a rhizotomy when you go to one of these outpatient centers. They may refer to it as radiofrequency. So what they're doing, they're using these little skinny probes to actually place into the back to burn and sever those nerve roots so that they're able to relieve any kind of chronic back pain that the patient's experiencing. Let's see. So you may not do that a ton. If they do that in the OR, you probably won't even really know that's what they're doing. So most of the time, this is done in an outpatient setting. Okay. Lastly, we're going to talk about basics, carpal tunnel and ulnar nerve. So the whole purpose, and I obviously do not know how to spell because I just realized that I'm an idiot. Well, doesn't need to be an E, it needs to be an A. But anyways, so carpal tunnel release. The whole purpose of a carpal tunnel release is to go in and to kind of open up the space because that median nerve running through has gotten trapped. So you need to go in, transect or resect across that transverse ligament, and it kind of opens up this little tunnel through here, and your median nerve isn't trapped anymore. That is what's causing all that numbness and tingling, and it feels like your hands are falling asleep because your nerve is actually entrapped in there. So, super basic procedure. Most of the time, they're going to use local, scalpel, some very basic, tiny, like a Hace little retractor or a little Wheatlander. They use tenotomy scissors to kind of open that space up. They do a lot of blunt dissection. And then you'll see them kind of pull on that nerve to kind of release it and stretch it out. And then depending on who you're with, once they've closed all that up, they will pat it up really, really good and then wrap the hand. So, pretty basic procedure. Doesn't take very long to do that. Next is your ulnar nerve transposition. I guess I didn't feel like everybody knew what an elbow was or where it was, but if you didn't, it is in the upper extremity. I don't know why I did that. So the main purpose of doing this ulnar nerve transposition. So what happens is the ulnar nerve is running along here, along through this little canal, okay? That cubital tunnel, right through here. So what happens is it starts to become trapped, okay? So you have that ligament of Osborn in there, and so you need to actually transect and move that nerve a little more anterior, because what's happening is it's slipping into that tunnel and getting compressed. So you have to open that up, because without doing that, this is where you're going to see patients that have numbness in their pinky, because it's their ulnar nerve, and a lot of times their ring finger. So notice if you ever hit your funny bone, that side of your hand is what normally goes numb. It's because you're affecting that ulnar nerve. So pretty basic stuff. I hope this helps. If you have questions, please let me know.